Alrighty. Hi guys, I'm Collette.
And I'm Andie.
So we're presenting a case from Mass General Hospital's Colonial Pathological Conference. This case was done by Dr. Andrew Benbez, Dr. Pamela Schaefer, Dr. Virginia Pierce, and Dr. Jane Luther. The case study is about a 32-year-old male in an unconscious state. Prior to being admitted to the hospital, he had been homeless. He had had a medical history of smoking a pack of cigarettes a day for the past 15 years, as well as drinking several pints of vodka a day. He had suffered from seizures, anemia, and paranoid schizophrenia. A blood test 6 years earlier tested that he was positive for the hepatitis B virus antibodies, and 14 months prior to his admission, he had suffered from subdural hematoma, shown here, where there's blood building up in the brain between the dura mater of your brain and your cerebrum, as well as orbital, nasal, and jaw fractures from an assault. 8 months prior, he had been admitted for altered behavior and was found to have elevated ammonia levels, liver fibrosis, and a fatty liver. So over here, sort of the stages of liver disease, and he came in that 6 months prior with both the fatty liver, which is fat deposits on your liver, and liver fibrosis, which is when scar tissue forms. Doctors administered lactulose for the liver disease, and finally he had been seen at the hospital 2 days before his admission for persistent nausea and vomiting. And earlier that same day, other people had noticed that he'd been acting pretty strangely. So on arrival, he was noticed to have a history of substance abuse disorders, traumatic brain injury, seizures, anemia, as well as a psychotic disorder. Upon arrival, he also had decerebrate posturing, noticed here, which is essentially when the brain neurologically disconnects from the body and the muscles are locked in an extensor position, as well as being incontinent with urine. He was hypoglycemic with a blood glucose level of less than 10 milligrams per deciliter when the normal range is about 70 to 110, so he was very low with that. He was tachycardic at about 112 beats per minute. The normal range is about 60 to 100, so it's not super high, but it's still noticeable. He was also hypertensive with a blood pressure of 170 over 119 millimeters mercury, when it's normally about 120 over 80, so his diastolic pressure was pretty high there. He was jaundiced and sclerotic. The sclera of your eyes is the white part around there, so basically his skin was all yellow and the whites of his eyes had turned yellow as well. His right pupil was sluggish, and he had spastic leg movements and clonus. And clonus is sort of just a jerking, repetitive movement of your muscles. A systolic flow murmur was also detected. His abdomen was slightly distended, and he had brain swelling and cytotoxic edema in his thalamus, cortical, and subcortical brain regions. So here, the two pictures on the right are his brain, and the two pictures on the left are the normal brain. And basically the effacement of the sulci was his brain swelling so much that the sulci and the gyri of his brain were essentially looking fused together, and you couldn't essentially differentiate them as they were pressing against the insides of the skull. And the cytotoxic edema here, sort of the same concept, where the liquid building up in his brain was creating pressure and causing it to expand. Imaging tests also displayed a partial collapse of the left lung, with this arrow is this little disc pointing out right there, as well as an abnormally thick gallbladder wall, which you can see up here. It's also called a hyperechoic gallbladder wall, basically meaning the ultrasound that couldn't see through the walls of the gallbladder. And this is associated with hepatitis, and also effacement of the sulci, which is essentially that gyri and the sulci fusing together. And effacement of the sulci is consistent with brain swelling as well. When the patient was seen at the hospital, 2 days prior to his administration, he was prescribed 650 milligrams of acetaminophen to be taken 3 times a day. This was in addition to his current prescription for 325 milligrams of acetaminophen to be taken twice a day. So in all, this patient was taking about 2,600 milligrams of acetaminophen a day, which is a very, very large number. So upon admittance to the hospital, he was intubated with an endotracheal tube and was given intravenous dextrose and lorazepam.
Could you just explain some of the what gyri are they?
Gyri, yeah, sure. So I don't know. You can kind of see it on this slide, but basically these little bumps right here are. Have you ever guys seen like a picture of the brain before, and it's kind of like has little lobes on it? and like the little ridges or the gyri and sort of the indents, I guess, are the sulci of the brain. So basically when his brain swelled and he had that abasement of the sulci, was basically that you couldn't really see the gyri of the brain anymore because it swelled up so much that it sort of just looked circular and you didn't see that pattern on the outside of the brain anymore. All right, so the collection of his many symptoms all pointed towards acute liver failure, but it presented a multitude of reasons of why it could be occurring. Propofol had been administered upon the patient's arrival to sedate him, but in diagnostic tests, including CT scans, viral serologies, which are blood tests, and PCRs, which analyze your DNA, as well as a liver biopsy, were all performed in order to try and figure out what was causing his liver failure. Everything you see up here in these red stars are all things out of the normal range, so you can see that this patient was indeed very sick. A lot of the levels over here, such as creatine kinase, it's at 1,306. The normal range is about 60 to 400. Same with alkaline aminotransferase is at 3,767, when the normal range is 10 to 40. So he definitely, he was way off the charts with a lot of his results, and a lot of those test results up there are things that are supposed to be filtered out by your liver. So after the lab tests were performed, doctors administered intravenous vitamin B and vitamin K because of his long history of alcoholism and its possible consequences of cerebral degeneration. Hydrocortisone and fresh frozen plasma were also administered to help with his liver disease. Finally, lactulose was administered again for the liver disease. However, it had been known to exacerbate dehydration and electrolyte imbalances, which he already had very low levels of, as well as not doing anything about ammonia levels, and his ammonia levels were exceptionally high, also causing his cerebral edema. So it wasn't the most effective drug they could have given him. N-acetylcysteine was also administered to counteract the effects of acetaminophen. It was also very beneficial because it also is known to counteract the effects of non-acetamin-induced hepatotoxicity, so anything, it basically would have helped whether or not acetaminophen was the cause of his liver failure. So it also helped, the non-acetylcysteine also helps with the hepatitis C infections. So, however, it only works best with grade 1 or 2 hepatic encephalopathy, which are these ones up here. Those typically range from mild neurological deficits, such as inability to move, tremors, anything like that. But he had grade 4 hepatic encephalopathy, which is a coma. He was completely unresponsive, and he had decerebrate posturing, which was that picture you guys saw earlier with the extensed muscles.
Alrighty, so his acute liver failure was due to high levels of alanine aminotransferase and aspartate aminotransferase. As you can see on the top levels, they were very, very high levels, and those high levels are only due to these specific diseases and reactions. So the first reaction that he could have possibly had would have been an idiosyncratic drug reaction, which is an unpredictable reaction to a drug. But he wasn't on the common drugs that caused this reaction, and he was hypertensive, not hypotensive, so it was pretty unlikely that he had this reaction. The next option was ischemic hepatopathy, but he was not hypertensive. He had no history of trauma coming in and no evidence of sepsis, like septic shock, and he also had normal creatine kinase levels that you can see over there, which ruled out ischemic hepatopathy. The next option, and also he had normal troponin levels, which also goes along with ischemic hepatopathy, so he didn't have that. The next option was Wilson's disease, but he didn't have the Kaiser rings, which are copper rings around your irises, and he also had normal, he had elevated alkaline phosphate levels, which doesn't go along with Wilson's disease, and he also had normal ceruloplasmin levels, so that ruled out Wilson's disease. As Collette mentioned earlier, he was given an extraordinary amount of acetaminophen, but when he arrived to the hospital, there was no evidence. It was an undetectable level upon arriving in the hospital, and his symptoms preceded his dosage being increased, so that ruled out acetaminophen-induced hepatotoxicity. The next two options of acute viral hepatitis with fulminant, which means sudden liver failure, and hepatitis A were both ruled out by a fever, and there were no other cases in his jail of hepatitis A cases, ruling out hepatitis A, which left the herpes simplex hepatitis, which would make sense because he was a chronic alcoholic and he was a prisoner, which prisoners are normally malnutrition and tend to skip meals because they're pretty unhappy. But his white blood cell count was normal and his HIV combo test was non-reactive, as you can see over here. So he didn't have herpes simplex hepatitis, which left three options that were all pretty rare, which is hepatitis B and D superinfection. It's pretty rare that you would have a co-infection when you have antibodies against hepatitis B, as Collette said earlier, but it can happen. When it does happen, you'll usually see more hepatitis D DNA inside of your body than hepatitis B because the hepatitis D virus will suppress the replication of the hepatitis B virus. So because he had such high levels of hepatitis B DNA in his body, he didn't have a co-infection, which just left us with him having hepatitis B. Now this is pretty rare because he did have antibodies for hepatitis B. So it can only really be explained by a couple of things, such as he was an inactive carrier. He had inactive carrier reactivation, which means that you have the antigens and you have the antibodies, but you also have a low level of DNA in your body, which means you have a low level infection, and it will reactivate itself later in life and create a full-blown liver failure, basically. He could also have incomplete or waning immunity, so you can have immunity to specific types of a virus and not to others. So when you get infected with the other type of a hepatitis B virus, you would become infected. And waning immunity is when your immunity wears off over time. And you can also have false positives, so he could have had, the test could have been incorrect, but that's also pretty rare, so it's pretty uncommon to see patients that come in with these antibodies and then actually have this infection. Another interesting part about this case was the fact that he had an autoimmune response with it. So he had these anti-smooth muscle antibodies, which are your body's attacking your own muscles, basically. And although it's rare, on rare occasions, it does occur with hepatitis B. And so what we think this patient had is that. So here on the left, you can see a really healthy liver. You see the light pink parts are the sinusoids, and the dark pink parts are the hepatocytes, and this liver is very functional. And when you look at the top right side, you can see a patient who has hepatitis B, and that's what his liver looks like. And these dark purple parts right here, that's fibrosis and cirrhosis, which is the scarring due to the swelling of your liver. So your liver will swell, and the sinusoids will be shrunken by the swelling, which are the little gaps between the hepatocytes, and it will cause this scarring here. And you can see like around the corners, the sinusoids are pretty much completely closed in, which is the white part, and there's no white between that nice magenta color, and that's what a hepatitis B patient's liver will look like. So for his final diagnosis, it was hepatitis B with an extrahepatic immune complex disease, which is that autoimmune response that he had with the HBV. He was given entecavir for his HBV, and he was also not eligible for the transplant or extracorporeal liver support, which is basically another way of filtering out everything that your liver can't filter out. And he was given hypertonic saline solution and mannitol for his cerebral edema. Due to the severe neurological damage that he had from his edema, his family decided to move him to a care facility, a comfort care facility, and he died on the third day in the hospital.
And that's our first set. Any questions? Yeah.
Just for the benefit of everyone here, in terms of thinking about toxicities for your liver, et cetera, what's the most common trade name for acetaminophen?
Aspirin.
If you're looking in your medicine cabinet, what would you looking at?
Tylenol.
Tylenol, exactly right. So Tylenol, which is portrayed as a very benign medication, if you take enough of it, isn't. It can kill you if you take too much of it, and usually by assassinating your liver.
Particularly in combination or in treatment for a hangover.
Yeah. Yeah, that's what we thought was particularly interesting about this, because it kind of led you into that. Well, obviously, it's acetaminophen toxicity, but I thought it was kind of cool. It's like a puzzle putting it all together.
Yeah.
So, anyone else? Yeah.
With such high doses of acetaminophen, I was wondering if there was any irregular bleeding or any irregular vomiting.
Prior to admission, 2 days before, he had persistent nausea and vomiting, which could be a result, but it's most probably not a result of the acetaminophen and more of the liver failure that was present at that time.
Did it say how long he appeared jaundice prior?
It didn't. I can't say who noticed it or why they were called. I mean, I would say it was probably a decent amount of time because EMS didn't get called until he was unconscious and decerebrate. So it was known that he was in liver failure, so it could have just been, or not liver failure, but liver disease. So they might have just thought it was not abnormal at the time.
And
How is hepatitis B transmitted? How do you get it?
You can get it, isn't it through like sharing? I'm pretty sure it's sharing like blood to blood through like shared liquids.
So that would translate into a street person doing what?
He would,
He was an intravenous drug user.
Okay, there you go.
Yeah.
And not necessarily street people, by the way. It's unfortunately way too common.
all
Yeah.
kinds of You're in vain. All right. Thank you very much.